Okay, let's unpack this. Today we're diving deep into your revision notes on parotid gland tumors. Think of this as taking that stack of facts and turning it into, well, a clear, high-yield conversation designed to really solidify your understanding and make you feel ready to tackle questions on this topic.
Absolutely. Revision notes are great for structure, definitely. But talking through the concepts, connecting the dots,
Yeah.
and highlighting the truly crucial bits, that's what brings them to life.
Mm.
And parotid tumors, they are common enough in head and neck practice that, yeah, a solid grasp is essential.
Right. So we're going to cover everything from your notes, what they are, why they might appear, what they feel and look like, how we investigate, the different ways we manage them, and, what the potential challenges and outcomes are. It's about building a confident framework based on the material you already have.
Okay, let's start at the beginning then.
Hmm.
What exactly are parotid gland tumors? Your notes define them as, well, abnormal growths in the parotid gland.
Which is the largest salivary gland, right? Tucked away near your ear. And the very first most important distinction to make, it's right there in the notes, is whether these growths are benign, non-cancerous.
Or malignant. Cancerous. That's the key split.
Exactly. And your notes immediately hit us with some really powerful statistics here, almost like a simple rule to keep in mind.
Ah, the rule of 80s. It's a great memory hook from the notes, isn't it? So about 80% of all salivary gland tumors are found in the parotid gland itself.
Okay, so if you encounter a salivary gland tumor, odds are it's in the parotid. Makes sense.
But taking that further, around 80% of tumors specifically within the parotid gland are benign.
Right. Okay. So that offers some initial, maybe reassurance, though obviously vigilance is still key.
Definitely. And finally, of those benign parotid tumors, approximately 80% are the specific type called pleomorphic adenoma.
Wow. That's incredibly high yield for an initial assessment, isn't it? If you feel a parotid lump, thinking, tumor, probably parotid, probably benign, probably pleomorphic adenoma, that gives you a really strong starting point for your differential diagnosis.
It absolutely helps prioritize your thinking. But while pleomorphic adenoma dominates the benign landscape, your notes list a wide spectrum of other types, which is crucial because, well, their behavior varies a lot.
Okay, so we have the epithelial tumors originating from the glandular lining itself. On the benign side, alongside pleomorphic adenoma, you mentioned Warthin's tumor, monomorphic adenoma, and oncocytoma.
That's right. And then the ones that raise significant concern, the malignant epithelial tumors,
Mm.
like mucoepidermoid carcinoma, adenoid cystic carcinoma, carcinoma X pleomorphic, that's the one where a benign pleomorphic adenoma turns nasty, acidic cell adenocarcinoma, squamous cell carcinoma, and undifferentiated carcinoma.
Quite a list. And the notes don't stop there, also mentioning non-epithelial tumors originating from other tissues in the gland. Hemangioma, lymphangioma, neurofibroma, neurolemoma or schwannomalipoma, sarcoma, and malignant lymphoma. Phew.
Yeah, it's a broad range. Thinking about that vast variety, why is classifying them right from the start so fundamental?
Good question. Why is it so important?
Well, because the classification dictates pretty much everything that follows. Is it benign or malignant? What specific type is it? That answers how aggressive it might be, what symptoms to expect, which investigations are most useful, how you plan surgery or other treatments, and ultimately, what the patient's outlook is. Knowing the specific type is basically the roadmap for management.
Okay, that makes sense. Roadmap. I like that. So we understand the sheer variety and the critical importance of classification. But why do these things show up in the first place? Your notes touch on the etiology and risk factors.
Interestingly, the notes explicitly state that the exact cause, well, it remains largely unclear.
Yeah.
We can't point to one specific thing for most cases.
But we do know some things that increase the risk, right?
Yes, the notes highlight a few key risk factors.
Yeah.
One is exposure to radiation, particularly previous head and neck radiation. That's a big one. There are also some inherited genetic conditions linked, and familial adenomatous polyposis is mentioned as an example. And as is common with many conditions, having a personal or family history of parotid gland tumors definitely increases your likelihood.
Okay. Thinking practically for revision or, a clinical scenario, why is knowing those risk factors important when you're talking to a patient?
Because it shapes your history taking. Simple as that. When a patient presents with parotid swelling, asking about past radiation treatment, relevant family history, or known genetic syndromes, it immediately raises your index of suspicion and helps guide your line of questioning.
Right. Got it. Now, there's just a brief section in the notes on pathophysiology. How do they actually develop at a cellular level?
Right, the notes keep this pretty concise. They originate from different cell types within the parotid gland. The specific molecular pathways and changes, they vary significantly depending on whether it's a benign adenoma, for example, or a malignant carcinoma.
And that cellular origin often ties back to the tumor name, doesn't it? Like an adenoma comes from glandular cells, a carcinoma from epithelial cells.
Exactly right. The name itself gives you a clue about the tissue it arose from, which is a key part of understanding its potential behavior.
Now, here's where it gets clinically really interesting, I think. You feel a lump in the parotid region. Is it always a tumor? Your notes give us a great list of differential diagnoses. What else could it be?
Oh, this is crucial for anyone assessing a parotid swelling. Absolutely crucial. The broad categories your notes mention are, yes, other salivary gland tumors, maybe a minor gland tumor masquerading, but also, importantly, non-tumor swellings like lymphadenopathy, cysts, or abscesses.
Okay, let's drill down into the specific non-tumor causes of parotid swelling listed. Acute sialadenitis, it's typically an infection, right? Often sudden onset and painful.
Yeah, that's the classic picture. Contrast that with chronic sialadenitis, which is usually less painful. The gland feels firm, maybe rubbery, and its size might fluctuate over time.
Then there are systemic or other causes. Mumps, the classic viral parotid swelling, though thankfully less common now with vaccination.
Definitely less common. Then sialolithiasis, that's a stone blocking the duct. Think swelling, often painful, especially when you start eating and saliva production kicks in. Painful stimulation.
Ah, yeah, makes sense. What else?
Sjogren's syndrome, an autoimmune condition affecting moisture glands like salivary and tear glands. It can cause chronic parotid swelling. Sarcoidosis, other inflammatory disease, can involve salivary glands too. And interestingly, alcoholic liver disease is also listed as a potential cause of non-tumor parotid swelling.
Wow, that's quite a range, from an infection to an autoimmune thing to a stone, even liver disease. How do we start to sort through these possibilities?
Your notes point to imaging and biopsy as the key tools here. Imaging like ultrasound, CT, or MRI helps characterize the lump. Is it solid? Is it cystic? Is it clearly within the parotid gland, or is it maybe a lymph node next door? And biopsy, especially FNAC, fine needle aspiration cytology, provides that crucial cellular information. Does it show inflammatory cells, suggesting sialadenitis, or is it tumor cells? And if tumor cells, are they looking benign or malignant?
Okay, so let's put that into a practical question for you, thinking like the listener. If someone walks in with sudden, painful parotid swelling, based on this list, are you primarily thinking tumor first or something else?
Pause. Good question. That pain and sudden onset should immediately make you consider acute sialadenitis, or possibly a stone, before jumping straight to tumor. The differential is wide. You need to keep it broad initially.
Okay, let's briefly look at the epidemiology, who gets these and how often.
Right. They're not the most common head and neck issue, making up about 3 to 6% of tumors in that region in places like the UK, according to the notes.
So you won't see them every single day, but definitely something you'll encounter in practice.
Correct. They are more frequent in adults, and there's a slight male predominance mentioned. Overall, the incidence is low, but their complexity and the need for careful management, especially for the malignant types, makes understanding them really crucial.
All right, let's talk about what you might actually see and feel when someone presents with a parotid tumor, the clinical features.
Okay. The most common presentation, according to your notes, is a painless swelling or a mass in the parotid region, just a lump.
Painless is often a sign of something benign, right? Is that fair to say?
Generally, yes. Benign tumors tend to grow slowly and don't invade nerves, so pain is less common initially. Other symptoms listed can include facial pain or numbness, or difficulty opening the mouth or chewing. This often happens if the tumor gets really large or starts pressing on nearby structures.
But this section also lists the absolute must-know signs that should make you highly suspicious of malignancy. These are your red flags.
Yes, these are critical. Let's list them and maybe add a quick why for each. First, hyperemic, hot skin over the lump, suggesting inflammation or maybe rapid growth.
Okay. Then pain. This is a key contrast to the usual painless, benign tumor. Why pain?
Pain can suggest invasion into surrounding tissues or nerves, or maybe inflammation secondary to the malignancy itself. It's a worrying sign.
Got it. Fixation. The lump feels stuck, not mobile.
Right. This indicates it's potentially invading the underlying muscles or the overlying skin. It's not just pushing things aside anymore.
Hard consistency often firmer than benign tumors, which can be more rubbery.
Yeah, malignant tumors often feel quite solid, even stony hard sometimes.
Irregular surface or ill-defined border benign tumors are often smooth and well-defined capsules, whereas irregularity suggests invasive growth.
Exactly. It feels less like a neat ball and more like something infiltrating.
And the biggest, most critical red flag from your notes: facial nerve involvement, weakness or paralysis.
This is the big one. Why is facial nerve involvement such a major warning sign?
Tell us.
Because the facial nerve, cranial nerve seventh, runs right through the substance of the parotid gland. It divides into its branches within the gland. A benign tumor tends to grow slowly and just push the nerve aside, which is why nerve preservation is usually the goal and often possible in benign surgery. But a malignant tumor is much more likely to invade the nerve sheath or the nerve itself. So facial nerve weakness or paralysis on that side is a very strong indicator that you are dealing with a malignancy.
Wow. Okay. That detail about the nerve running right through the gland makes the potential complications of surgery immediately understandable, but we'll get to that in a bit. First, how do we confirm the diagnosis? Investigations.
Your notes state clearly that diagnosis relies on a combination of things: clinical features, imaging, and most definitively, histology. You need that tissue sample.
And the go-to initial investigation mentioned seems to be FNA fine needle aspiration cytology.
Yes, FNAC is usually the first step for a palpable lump. It's minimally invasive. You use a thin needle to get some cells out. It gives a pretty quick answer on whether the lump looks benign or malignant based on the cytology. It can even suggest the type, though it's not always 100% definitive for the specific type compared to a larger biopsy, but it's excellent for guiding those initial management decisions.
Okay, what about imaging? CT and MRI scans, when do they come in?
These are used particularly if you suspect malignancy based on clinical signs or the FNAC, or if the tumor is large or feels deep. They help clarify if the mass is truly within the parotid gland, assess its size, and crucially, look at its relationship to important nearby structures, especially the facial nerve, and also check for any potential spread to lymph nodes in the neck. MRI generally gives better soft tissue detail, especially around the nerve.
Any other investigations worth noting from the list in the notes?
Yeah, a couple. The notes mention an X-ray specifically for detecting stones if silothiasis is high on your differential list. Calcium stones might show up. Celography involves injecting contrast dye into the salivary ducts to visualize them, good for duct blockages or structural issues. And silendoscopy allows direct internal visualization of the ducts with a tiny camera. And you can sometimes even use it therapeutically, like removing small stones or debris.
So, quick recap question. If you suspect a parotid tumor, which investigation is usually the first line for initial characterization of the lump itself?
That would generally be the FNA, get those cells first.
Okay. Once we have that diagnosis confirmed, how do we treat these things? Management.
As your notes emphasize, management is highly dependent on the tumor type, its stage, and often involves a multidisciplinary team: surgeons, oncologists, radiologists, pathologists, because of the complexity involved.
Right. The main options listed are surgical removal, called parotidectomy.
And for malignancies, radiation therapy or chemotherapy might also be used, often in combination with surgery.
Surgery seems to be the cornerstone for most parotid tumors, both benign and malignant. Let's look at the management for the most common benign type: pleomorphic adenoma.
Okay. Your notes specify surgical excision using a specific approach, often a modified Blair's incision. The extent of the surgery depends on the tumor. Usually a superficial parotidectomy for tumors sitting in the superficial lobe, that's the part above the facial nerve, or a total parotidectomy if the tumor is very large or involves the deep lobe, the part below or deep to the nerve. But the absolute goal here for benign tumors like pleomorphic adenoma is preserving the facial nerve. That's paramount.
That makes complete sense. If it's benign, you want to get it out cleanly but protect that vital nerve. But what happens if that pleomorphic adenoma transforms into a malignancy, a carcinoma ex pleomorphic?
Yeah.
How does the management change?
The notes show a stark change in approach. It becomes much more aggressive. This now typically requires a total parotidectomy and often necessitates sacrifice of the facial nerve if it's involved by the tumor. Though nerve grafting might be attempted later to restore some function, this surgery is usually followed by adjuvant radiotherapy to kill any remaining malignant cells. And if there's evidence of spread to neck lymph nodes, a radical neck dissection is also part of the treatment plan.
Wow. See how the diagnosis completely dictates the approach? Benign versus malignant, even starting from the same tumor type initially, leads to vastly different surgery nerve sparing versus potentially nerve sacrificing.
Exactly. It underscores why accurate diagnosis is so vital.
And what about the second most common benign type, Warthin's tumor? How's that managed?
Your notes suggest conservative management might be an option if they are asymptomatic and confirmed to be Warthin's, perhaps in an older patient. But if they are troublesome, growing, or the diagnosis is uncertain, a superficial parotidectomy is the standard approach, again, aiming to preserve the nerve.
Okay, so surgery is clearly key, but also involves that delicate facial nerve running right through the operative field. This brings us to a major section in your notes, the potential complications of parotidectomy. And there are quite a few listed here.
There are, yes. And they are helpfully grouped by timing in your notes, which is a really good way to remember them for exams or practice.
Let's run through them. Immediate, meaning during the surgery itself. The most feared is transection of the facial nerve, or one of its branches, resulting in immediate lower motor neuron facial palsy, that classic Bell's sign appearance on the affected side.
Also, tumor capsule rupture. This is particularly concerning for pleomorphic adenoma with its sometimes thin capsule. Spilling tumor cells can lead to seeding and recurrence down the line. And obviously, incomplete tumor resection, leaving some tumor behind.
Okay. Then there are the early complications, within about a month post-op. Temporary facial weakness called neuropraxia. This is more common than permanent damage, usually from stretching or bruising the nerve during dissection. It typically recovers.
That's right. Division of the great auricular nerve is almost unavoidable in many approaches. This nerve supplies sensation to the lower part of the earlobe and angle of the jaw, so patients get numbness there.
What else early on?
Parotid fistula, where saliva leaks from the surgical wound or incision line. Trismus, which is difficulty opening the mouth fully, sometimes from swelling or muscle spasm.
Wound infection or seroma, a collection of fluid under the skin flap, or a hematoma, a collection of blood.
Yes, standard surgical risks. And then a couple of more unusual, named early complications. First, bite syndrome. Imagine taking your first bite of food, especially something that stimulates saliva strongly, and getting a sudden sharp spasm or pain in the parotid cheek area. It's thought to be due to sympathetic nerve disruption. It usually improves over time, but can be quite unpleasant.
Distinctive. And the other one?
Skin flap necrosis, where the edge of the skin incision doesn't heal well due to compromised blood supply. More common in smokers or patients with vascular issues.
Wow, that's a comprehensive list just for the early phase. What about the late complications, appearing months or even years later?
These are often the longer-term consequences, frequently related to nerve regeneration, sometimes aberrant regeneration. Facial synkinesis is one, sometimes called Bogorad syndrome or the more memorable crocodile tears. This is when regenerating nerve fibers meant for salivation mistakenly grow towards the lacrimal gland. So the patient tears up, hyperlacrimation, when they eat or even think about food.
That sounds incredibly inconvenient, crocodile tears while eating.
It certainly can be socially awkward, yeah. Related to that, and perhaps more common, is Fraze syndrome, also known as gustatory sweating. Here, nerve fibers from the auriculotemporal nerve, originally going to the parotid for salivation, mistakenly reinnervate the sweat glands in the overlying cheek skin after surgery. The result is sweating on the cheek and temple area when the person smells or eats food.
Another classic memorable complication tied directly to the nerve anatomy and the surgery, Fraze syndrome.
Exactly. Other late issues can include persistent, great auricular nerve hypoesthesia, that's ongoing numbness of the earlobe area, tumor recurrence, which can happen years later if the initial resection wasn't complete, if the capsule ruptured, or particularly with malignant or high-risk tumors, and cosmetic issues, sometimes a noticeable depression or soft tissue deficit where the gland was removed, or problems with the scar like thickening or keloid formation.
That whole list of complications really highlights the delicate nature of this surgery, doesn't it? Primarily because of that facial nerve. It's not just about getting the tumor out.
Absolutely. It's a fine balance, particularly in malignancy, between achieving clear surgical margins, getting all the cancer out, and preserving nerve function, and minimizing these other long-term impacts. It requires significant expertise.
Okay, bringing it towards the end, now what's the outlook? The prognosis for parotid gland tumors, based on your notes.
Your notes are pretty clear on this. Prognosis depends significantly on the tumor type, benign versus malignant, and the specific subtype. Its stage at diagnosis, how advanced it is, and the patient's general health and age.
Benign tumors, as you'd expect, have a very favorable prognosis once successfully removed. They don't spread elsewhere. Recurrence is possible, but usually low with complete excision.
That's right. Malignant tumors, however, have a prognosis that is much more variable. It depends heavily on the stage how large it is, whether it has spread to lymph nodes or distant sites like the lungs, and the histological grade, meaning how aggressive the cancer cells look under the microscope. High-grade, advanced-stage tumors have a poorer outlook.
So for malignant tumors, finding them early, when they're small and haven't spread, makes a really big difference in the potential outcome.
Precisely. Early diagnosis and accurate staging are absolutely critical for managing malignant parotid tumors effectively and offering the best chance of cure.
Your notes also list general complications, which seem to loop back on some of the treatment complications we just discussed.
Yes, this section seems to reiterate the important potential long-term issues arising from the tumor itself or its treatment. Things like temporary or permanent facial weakness or paralysis from nerve damage. Other nerve injuries like the great auricular, sensory changes, infection, bleeding risks associated with surgery.
And it includes the rarer, but obviously most serious complications. Malignant tumor recurrence locally or metastasis, the tumor spreading to other parts of the body.
Which underscores the final point made in your notes.
Huh.
The absolute need for ongoing, long-term follow-up.
Essential, you mean?
Totally essential.
Yeah.
It's not just about the initial treatment phase. Regular checkups are needed to monitor the patient's recovery, manage any persistent complications like Frey's syndrome or facial weakness, and crucially, to detect any sign of tumor recurrence as early as possible, especially for malignant tumors or benign ones known to have a higher recurrence risk, like pleomorphic adenoma if the capsule was breached.
Okay. We've covered a significant amount of detail from your notes today, really unpacked it. From the different types and that key rule of 80s, through the red flags for malignancy, the investigations like FNAC, the complexities of surgery, and its potential complications like Frey's syndrome, right through to prognosis and the need for follow-up.
It's definitely a topic packed with important details, and hopefully talking through it in this structured way helps solidify those connections in your mind, linking the pathology to the clinical features and management.
So as you go back over your notes after this deep dive, here's something the expert might want you to consider.
Yeah, maybe think about this. Given that wide range of tumors we discussed, from the very common, generally well-behaved pleomorphic adenoma, all the way to aggressive nerve-invading carcinomas, what does that complexity tell you about the non-negotiable importance of getting a definitive tissue diagnosis, usually from that FNAC or maybe a core biopsy, before finalizing the surgical plan? Think about how that single piece of information, benign versus malignant, and ideally, the likely type completely shifts the entire management strategy, especially regarding the facial nerve, from potentially nerve-sparing to potentially nerve-sacrificing.
It really highlights how anatomy, pathology, and surgical planning are so intricately linked in this very small, complex area of the head and neck.
Absolutely. A fascinating area.
Well, thanks for joining us for this deep dive into your notes on parotid gland tumors. Hopefully, revisiting your material with these points in mind will make everything click even better.
And if you're looking for more resources to help with your revision, remember you can always check out PassiveSRA.com.
And also freemsra.com for additional materials.
Until the next deep dive.
Keep exploring, keep learning.